How about now? Can you hear? Good. Okay, if you want to either ask or type in a question, I will jump right on it. We will get this thing going. Okay, yeah, we can do that. Let me share. Let me open it up first. Let's see. Got it. Let's see. Maybe this one. Thank you. Okay. All righty. Let me share with you. If we can. Let's see. There we go. Okay, you guys should be able to see this. If not, right this second, and in a minute, just a moment. Okay. Okay, starting with the hormones. Let's see. The posterior pituitary hormones are going to be the oxytocin and the antidiuretic hormone, ADH. These guys are manufactured in the hypothalamus itself, and then they go down these axons where they're stored and they're released upon the appropriate signals, the neural signals that are going to let them know. Oxytocin positive feedback is going to be for enhancing labor contractions, and it's also going to get the myoepithelial cells in the breast to eject milk. ADH, we hadn't got to the kidneys yet. What we really need to know is that it helps us to reabsorb water. And the reason it's called antidiuretic is that it retains water. We also have this as an artificial form, vasopressin. Anyone that is dehydrated, especially if their blood pressure is down, will give them vasopressin to try to get more water. It's not an emergency thing, but it's something. Diabetes insipidus, remember that. That's ADH not functioning, whether it's from the pituitary or it's from the brain, or it could be something is going wrong in the kidney. Doesn't matter for our purposes right now. The fluid loss can top up to half your body's fluid, and that is not compatible with staying alive. So does that sound pretty good on the posterior pituitary? It does. I'll go on to the next slide. Show.
Yes.
We good, guys?
I'm good.
Okay. Well, let's stop sharing this one so I can get rid of it and get the next one up. Okay. And let me share this one with you guys. There he is. Okay. And you guys should be seeing it about right now. The anterior pituitary. These guys actually make the hormones, but they have a blood vessel system called the hypophyseal portal system, and the hypothalamus is going to send hormones to cause them to release their hormones. It gets kind of involved, but it's not too awfully terrible. Okay, 6 hormones: growth hormone, prolactin. These guys directly affect their target organs. They are going to cause things to happen. Growth hormone, along with thyroid and all this, this guy is going to cause us to build more muscle and bone. The prolactin is going to cause the breast to produce milk, and this is going to be due to the high estrogen levels going on in latter pregnancy and so forth. And then the baby is going to stimulate neural sensors. And so the prolactin makes the milk, the oxytocin causes it to be ejected. Okay, those are the 2 non-tropic hormones. The tropic hormones are TSH, ACTH, FSH, and LH. Only thing we need to know at this point in time, FSH is going to cause the development of cells. And it's going to cause the egg cell to develop in the ovary and the sperm cell in the testes. LH is going to cause the testes to produce testosterone and cause the ovaries to produce estrogen, progesterone to a degree. We're not going to go into a lot more details. TSH goes to the thyroid, where it causes the thyroid to make and most especially release thyroid hormone. ACTH is going to the cortex of the adrenal gland, where it's going to cause the zona fasciculata to produce cortisol, the stress hormone. That's basically what these guys do. That's their thing. Growth hormone, without going into a lot of detail, is going to mobilize sugar. It's going to get everything ready so that we can make energy, so that we can grow, doing a lot of cell division and all that. Thyroid hormone is going to be there. The proximal cause of all this is going to be the IGFs, the insulin-like growth factors. These guys are what the growth hormone is basically going to stimulate. Growth hormone is going to be controlled by 2 hormones coming from the hypothalamus. GHRH is going to release growth hormone. GHIH is going to inhibit the release. And these guys are going to be dependent on the levels of growth hormone and IGF. If these levels go up, then this guy's going to shut off, and this guy's going to start being secreted to kind of slow it down. The things that happen when we're out of balance. Gigantism is what happens to people whose growth hormone is increased before the epiphyseal plates close in the bones. That's going to cause gigantism, and it has a lot of problems with it and don't live very long. Acromegaly, on the other hand, is what happens when you get it in adults. The hands, the feet, and the face are going to grow. The face is going to get very coarse looking because of the growth of all those bones. So this is too much GH. This is not enough. And this is called pituitary dwarfism. And unlike the folks that they used to call midgets, their head, their chest, their torso is in proportion to the size of the arms and the legs. Whereas in achondroplasia, the person is going to have a normal sized torso and head, but their arms and legs are going to be abnormally short. And that's because the epiphyseal plate closes. TRH comes from the hypothalamus to the pituitary, causes TSH, goes there, releases thyroid hormones. As the levels of thyroid hormones go up, then it's going to go and act on both the anterior pituitary and the hypothalamus, causing those levels to drop. Just to let it know we've reached our goal, so we don't need to continue to do this. CRH, corticotropin releasing hormone, it comes from the hypothalamus to release ACTH, and it's going to go again to the zona fasciculata and cause these guys to release the cortisol and the other corticotropic hormones there. Okay, and this, I said, we're going to cover most of this. This is all you really need to know for this chapter. So we're not going to go into a lot of detail on this. Prolactin, we don't have a releasing hormone for it. We have an inhibitory hormone. Prolactin is unusual in that it is naturally turned on and it actually has to be turned off. So we don't need a releasing hormone. All we've got to do is shut down the dopamine, the prolactin inhibitory hormone, and it will start producing. Okay, that's kind of interesting. It's a good overview, but this one I don't do a lot with. The intermediate pituitary, we don't even go into that in the lab. It's between the anterior and the posterior. This guy is going to release something called MSH, melanocyte stimulating hormone, which is going to cause the melanocytes to produce more melanin to protect our skin from ultraviolet. Melanin can be produced by the melanocytes on their own, so nobody's really sure what real good that is. Thyroid hormone produces thyroid hormone. The three parts of this guy, the colloid, which is kind of like the pool, the follicular cells, which is like the edge or the concrete around the pool. The follicle is just the entire thing. It's the colloid plus the parafollicular cells. These are the guys that make the thyroid hormone, and then they put it in here in storage. And there's about 2 weeks worth of hormone in there. Don't worry anything about this. Thyroid hormone just comes in two forms. Probably about 80% of it is going to be T4. Maybe 20% is going to be T3. But when this guy gets to the cells, they can cut this guy off and change it into T3. This is one of those hormones that comes from an amino acid, tyrosine. So you basically have two tyrosines connected right there by the oxygen, right there. Dehydration synthesis. And then you attach iodine molecules to it. That's pretty much all it. Thyroid hormone is like the gas pedal. It speeds up your metabolism. So the faster it goes, more quickly your body chemistry goes through that. And of course, it produces heat as a side effect of that. Thyroid hormone, even though it's an amino acid, it's also lipid soluble. So that means that this guy can go straight through the plasma membrane. So he doesn't use second messengers. But since he's lipid soluble, it also means he has to be buried inside a protein that is neutral on the inside and charged on the outside, like the steroid hormones. Myxedema, you hardly ever hear that term anymore. Basically, they just call it hypothyroidism. It can come from a lot of things. The thyroid could be attacked by autoimmune. That's Hashimoto's. That's very common. And sometimes this guy will produce a goiter. Now, a goiter you can also get in hyperthyroidism, but what's happening is this guy is not producing the thyroid hormone. So what happens is the TSH, it just keeps rising higher and higher. So basically, this guy is just shouting at him, you need to produce. And so he gets larger to try to carry out that order. But it doesn't do any good because if he's lacking something, whether it's the iodine or, the cells are damaged and they can't, whatever it is, that's kind of the situation. This is super easy. You can give people thyroid hormone. It costs like $4 a month. It's generic, no big deal. The signs and symptoms of hypothyroidism, the menstrual flow will get kind of wonky, won't be regular at all. The person will act slow physically and mentally. I mean, his metabolism is down. Dull facial expression, fatigue, confusion, puffy. Some of the eyebrows can fall off. And if you're not producing enough thyroid hormone, that means you're not making all that extra heat. So you're going to start feeling cold a lot. And you're also not going to be using as much ATP. So you're going to gain some weight. And you're going to be constipated because everything is moving slow. Muscle cramps. The skin will be very dry and brittle, or the hair will be very brittle and dry. So that's hypothyroidism. It's fairly common running around. Now, this is a very sad situation where if mom doesn't have enough thyroid hormones, maybe she's lacks iodine. And back in the day, if you didn't live by the ocean, you really didn't have access to it. This is called cretinism. The baby's thyroid is going to be permanently damaged, severe and irreversible mental defects, stunted growth. I'm guessing that's about a yardstick, about 3 foot. And many of the organs are also going to be underdeveloped. There's no thyroid hormone. You can't speed up your metabolism. Things aren't going to be well developed. It's a sad situation that can be fixed with iodine for the most part. Graves' disease is hyperthyroidism. In hyperthyroidism, you're producing a lot more than you need. You're actually speeding up your metabolism beyond what you need. So when this happens, here's some of the ways you can tell. If my TSH levels are low because that excess thyroid hormone has shut it off, but my thyroid hormone levels are high, that's hyper. And if you remember what I said the last time for the hypo, if the TSH levels are high, but the thyroid hormone levels are low, then that means the brain knows that it doesn't have enough, but the thyroid gland can't produce it for whatever reason. Let me get rid of some of that so we can see these signs and symptoms. Okay, Graves' disease, what happens is an antibody is going to bind to the receptor, and this antibody fits that receptor just like TSH would. So it actually permanently binds. So it's like this guy, the thyroid, is being under the impression that the brain just keeps calling for more and more. The actual TSH levels are low, but it doesn't matter. So if the hypo was cold-natured, you're going to be hot-natured, you're going to be thin, you're going to be sweating, even have little tremors in your hand because of all the excess energy. Muscle weakness, you can have a very little, very tiny menstrual cycle, and instead of constipation, you got nausea and diarrhea. It's going too fast. This is the problem with this as opposed to the other, is the arrhythmia and tachycardia can have effects on your heart. You can get the goiter too, because if this guy keeps telling the thyroid hormone more and more, it's going to get bigger. This is one sign that is pretty obvious if you see it, if it's present. Exophthalmos, the eyes will protrude from the sockets because of increased pressure behind there. All right, guys, we good on the anterior pituitary stuff?
How much of the endocrine system is going to be on this test?
Well, we've got 3 chapters and 50 questions. So let's say, I think that comes down, let's say 18, 18, and 17. Is that right? Let me think. 50 divided by 3 is going to be 1. And it's going to leave 20, 13. I'm sorry. 13, 13, and 12, I believe. No, that's still not enough. You know, why am I trying to do this when I've got a calculator right here? Okay, 16 and 17 and 17. Yep, that's it. So if this is the lowest chapter, which probably won't be because we've got the blood and we don't have as much on that. So I'd say probably about 17 questions from here.
Okay, thank you.
Are we good with this PowerPoint, guys, or is there anything else you want me to go over?
I'm good.
Okay.
I'm good too.
Okay. Let me get the last one up and we'll be done with these guys. It's going to be talking about some of the other organs that we need to be aware of. Okay, let's share this one with you guys and we'll go. All this stuff is being recorded, so it'll be online if you need to refer to it again. Okay, let's share this and it should be roundabout now. Okay, the parathyroid, the only thing this has in common with the thyroid is they hang out in the same place. They are totally different. They don't look the same histologically. This guy makes parathyroid hormone, PTH. PTH's only function is to break down bone and cause us to reabsorb, put more calcium into the blood because our calcium levels are low. This guy directly detects the calcium levels. And helps also in the GI tract and the kidneys, but I don't want to go there. Helps the kidneys turn vitamin D, but that's its main function. Now, calcitonin, I didn't talk about that in the thyroid. It's actually part of the thyroid. It's supposed to help us lower our calcium levels, but it doesn't work very well. It's kind of useless. So that's why I don't spend a lot of time with that guy. Parathyroid is pretty straightforward. The adrenal gland, two main regions, the cortex, the outer part, and the medulla. Sometimes they call this the suprarenal because it sits on top of the kidneys, or adrenal sits on top of the kidneys. It doesn't really make any difference. These guys are divided up into parts. So the cortex is actually comes in three parts. And there's the medulla. The zona glomerulosa, these are the guys that are going to produce the aldosterone. That's another one of those guys that help us when we're dehydrated. We'll find out more about that in the kidneys, but for this test, it helps us to retain water. The fasciculata, that should be an A. This guy is going to be what I just said, going to be producing the cortisol based on the ACTH he gets. Aldosterone coming from this guy has a very complicated generation, and I usually cover it with the kidneys, so don't worry too much. Aldosterone, there's a reason it gets released, but we're not going to go into it right now. The reticularis, these are the guys that make the sex hormones. So in a female, this is where testosterone is made, and in a male, this is where estrogen is made. And we all make all hormones. It's just the way it is. Let's see. Aldosterone comes from cholesterol, same ring. The only difference is some of the molecules hang off the side. And we're not going to talk a lot about this. There's one other thing that will cause us to release aldosterone, and that's as if our potassium levels are high. High potassium is dangerous, so this is kind of important. So in addition to helping us retain water, it also helps us to get rid of potassium. And even if you're not dehydrated, if your potassium goes up, you're going to make aldosterone to get rid of it. Cortisol, we've kind of talked about this guy. Come over here. Well, I don't want to talk about the pathology. Cortisol is the chronic stress hormone. It comes from the ACTH, and just like everything else, once the cortisol levels rise, it's going to shut off CRH and ACTH because we're at the level we need to be. These guys are going to help us by suppressing our immune system. That sounds like a funny way to help us. And they're also going to raise our blood sugar levels. This is also going to cause some problems along the way, but we really don't want these guys to be turned on a lot. It's really a bad thing. It breaks down fat and all that. Okay, you can have two problems with cortisol. You can have too much of it, in which case you've got Cushing's disease. High blood sugar levels, that's the same as diabetes. You're going to lose muscle and bone protein. You're going to retain salt and water, and that's going to lead you to high blood pressure and some edema. You're going to get what they call a moon face, rounded. That buffalo hump right there is probably one of the most pathognomonic things about that. Abdominal fat, bruising, because you're not going to be producing the clotting hormones. Poor wound healing for basically the same thing. And you can see these stretch marks on there. Oh, wait a minute. Why did they put Addison's disease there? That's Cushing's. This is not as uncommon as you might think. And one thing that can be really very devastating, especially, obviously for females, is hirsutism. Because this is going to be going full out, you can also get an excess of testosterone, which for a female will cause them to start having facial hair. And that's a problem. I don't think, yeah, we do have Addison's disease over here. That's where you don't have enough of this. You're going to lose weight, your blood sugar levels and sodium are going to drop, potassium levels are going to go up, severe dehydration, low blood pressure, bronze pigmentation of skin. Again, you can get some very weird body hair, especially for females. Hypoglycemia. Postural hypertension just means when you stand up, your blood pressure drops way, way too much. Weight loss, GI weakness, very severe fatigue. This can be lethal if it's not treated. Okay. Testosterone in both genders is responsible for libido. Androgens are going to start puberty in both genders. And for the males, it's going to be the secondary sex characteristics, such as the facial hair and the muscle pattern. The medulla just has epinephrine and norepinephrine. And this guy's really ties right in with the sympathetic system from AMP1. When the sympathetic system, your fight or flight, gets activated, the sympathetic nerves send a signal straight to the medulla, and this guy is going to flood your body with adrenaline, and you're going to be hyped up for quite a while. Let's see. Short-term stress is going to be the sympathetic, the long-term is cortisol. I think we've talked about that before. Pineal gland, melatonin, it has some influence on sexual development, but mainly we think about this guy as sleep-wake. And it kind of keeps our internal clock in sync with the sunshine around us. So if you go somewhere where noon is going to be different than it was in the place that you started from, you're going to be out of sync, but it will eventually will adjust to that. Let's see. There's also, and you guys may have heard of seasonal affective disorder, they call it SAD, S-A-D. This guy is when you don't get enough light striking, and that's going to be tied in with your melatonin, that it can actually cause your serotonin levels to drop, which gives you clinical depression. Pancreas. The only thing we're going to be concerned with right now is the endocrine part on this pancreatic islet right here. And we know that this is just going to be insulin and glucagon. Insulin is going to take all those that sugar in your blood after you eat and move it someplace where it needs to be, either in the cells, in storage, or converted into a long-term storage of triglycerides. Having prolonged high blood sugar causes eye damage, causes nerve damage, causes damages to your blood vessels. This is a bad thing. So insulin is critical. Glucagon, on the other hand, when your blood sugar starts going way down in the middle of the night, when it's been a long time since you've had any food, this guy is going to get some of that stored glucose and release it so that you don't get such a big wide swing in your blood sugar levels. Hypoglycemia, if it gets down into 30s or 40s, you have to go to the ER for that. Although you could just, eat a candy bar, or you could just eat. I'm not sure what they're calling what, because they change it every so often. They're saying that normally you should have less than 200 milligrams of sugar, glucose, after eating. Maybe 80 to 100 fasting. And that's the way we always check it. 101 to 125, somewhat impaired. Some people will call that pre-diabetic. It depends on whether they're selling pills to, or not. But
Do we need to know that chart?
no, it changes. What you need to know is that if your glucose levels are elevated above whatever is considered normal nowadays, then you may have an impaired glucose processing. Something's going wrong. And it depends. There's 3 types of diabetes. Type 1 antibodies attack the beta cells and you lose the ability to make insulin. Pretty straightforward. Type 2, which is what most everyone has, you put on too much weight, which means you are going to have these cells become more resistant to the insulin that you do make. And then if you get high enough, then, fasting, then you're going to be classified as diabetic. They actually do something called hemoglobin A1C. That is a picture, a snapshot of what's your blood sugar, but the A1C gives us a picture over the last 3 months. And when I was doing it, it was 6. Oops. It was 6 that was the number, but I think they've dropped that down to like 5.6. Anyway, that's more than you guys need to know. So we've already talked about that. They think that there's a virus that looks similar to beta cells. And so the immune system gets hopped up and takes out. Type 2 insulin resistance. Gestational, this is something that can happen to some women when they're pregnant. Sometimes, especially if they don't try to do something about it, it will develop into type 2. Of course, some mothers never lose the weight they gain, which is not a good thing, but it's a free country. So diabetes mellitus, don't confuse it with diabetes insipidus. The 3 main signs we're going to see on this is polyuria. Someone is going to be going to the restroom a lot because if glucose doesn't get taken out of the kidneys and put back into the blood, then it's going to draw water in by osmosis. So you're going to fill up your bladder a lot. And since you're going to the bathroom a lot, you're going to have polydipsia. You're going to be thirsty a lot. And since you can't get the insulin or the sugar into your cells, you're going to be hungry a lot. So polyuria, polydipsia, and polyphagia are our main signs. I don't think we got anything on there. I don't know what that's doing there. Anyway,
Can you
yes.
ask us, give us a couple examples of how these questions will be worded on the test?
Oh, one of the ways is just list the cardinal signs of diabetes, and you've got multiple choice. And you just have to know the three that are on there. As far as the type 1 and type 2 diabetes, probably ask you about what causes them. The treatment, type 1 diabetes, you basically just got to give them insulin from the get-go. Type 2, a lot of times they'll start it off with glucophage and gradually add into that. That high sugar is also going to damage the kidneys. So untreated, uncontrolled, somebody that's not really trying really hard, they're going to wind up on dialysis. Their kidneys are going to die. And so they're going to have to go to dialysis. So know the causes of these. And also, I mean, that's just no insulin. I've got insulin here. It may be high, it may be low, but the cells, they're not paying any attention to it. Does that make sense?
Yes. But I was talking about like the endocrine system as a whole, because there's so much information to know. It's just a lot to know what to study to
It
focus
is.
on.
Well, just about everything in here, unless I just tell you that it's FYI, is kind of important. Except for these guys, that we're not going to be going into this until the end of the semester. There's a lot in here, guys. But if you watch my videos, and you can watch this review video again if you want to, because it's going to be several days before we actually do our test, you can see the things that I'm bringing out. That's the things that are most important. But not only do I have to prepare you for my test, I also have to prepare you for an unknown test at the end of the semester that I have no idea who's going to be giving it. So that's why I tend to go a little overboard on these PowerPoints, because I don't want you guys to get blindsided on that. But yeah, there's a lot on here, guys. No doubt. Okay, that has got our endocrine pretty much taken care of. What else is on your mind? What else are you guys interested in?
I'm
Talking
still super
about-
confused. I'm still super confused
About-
with the cardiac cycle and the EKG.
Oh, yeah. Yeah, cardiac cycle can be a booger. Let me see.
You
We'll
have
go to
people
that.
doing the comments in the chat, and someone said, "Is the test based off of the learning objectives?"
The learning objectives are what the school tells me I need to teach you guys. So to a degree, that's true. But I would look and see what I've got in these PowerPoints. That's going to be one of the most important things, because obviously what I think is the most important is what I put in here. And I know the PowerPoints are long, but sometimes it's just me telling you the same thing in a different way. So it's not quite as onerous as it could be. So if you guys are having questions about the Wigger's diagram, the cardiac cycle, let's go ahead and open it up. And that should be it right there. we're going to do this one in red. So it looks like we've got a lot. It's pink. It's red. Okay. Okay. If you watch that video that I did you the quiz on, that guy was talking about the cardiac cycle, and he was going this way. He was taking this piece and this piece and this piece, and that's a good way to do it. That's one of the reasons I wanted you to watch that. I usually go from top to bottom and tell you about what's going on in different places. So the EKG should be pretty familiar to you guys now. P wave, the atria are getting their go signal, so they're going to be contracting. And then that go signal is going to make its way to the ventricles, but it's going to be held up at the AV node for a split second to allow the atria to completely clear out their blood before the ventricles start pushing back. And that's that little flat line right there. Then the ventricles, finally, the signal gets through. Okay, come on now. Play pretty. And then we're going to get the QRS complex. It's three different waves, but we'll just consider it as one. And that's going to be when the ventricles are going to get the electrical signal to contract. Now, guys, this EKG is not, I'm telling you contraction, but this is actually just the signal. That's all this is. This is the electrical part of what's going on. The pressure part we'll talk about in just a second. And then during the time of the QRS, the atria will repolarize, they'll recharge, they'll reset for the next cycle. They're kind of buried in there. But the ventricles, we're going to have a T wave, and that T wave is going to be when the ventricles are resetting. So there's the P, the QRS, and the T right there. And there's the beginning of the next cycle. Well, actually, yeah, we'll call that. We go from P to P. That's good. So there's one cardiac cycle. They got it kind of stretched out, but they're doing that for a purpose. Now we're going to skip the heart sounds for a second, because the next thing we need to talk about is where is blood moving? Where is blood going to move? It depends on who's got the highest pressure. Like that guy said, and like I've told you before, if you got two guys pushing on a door, which way the door is going to go is going to depend on who's strongest. If you got two or three guys pushing on the door from one direction, it's going to move in their direction. I mean, they're going to be able to move it past the opposing force. So we've got pressure. So let's go down here at the bottom first. That purple is the pressure in the atrium. So normally it's very, very low. I mean, it's low, super low, about 10 maybe less, probably 8. So that's, the atria are not contracting because the atria contract when the P wave. So this is going to stay low, and then that signal comes in, the electrical signal, and then the muscle squeezes. And it's going to squeeze and push the blood into the ventricle, or the remainder of the blood. When that happens, you're going to see this little bump. That's because the pressure is going up, because instead of just falling straight through, it's now squeezing, being pushed in there. And that's going to go, and we'll talk about this C wave in just a minute. But basically, once this guy relaxes during the QRS, he's going to stay low and low until the next atrial contraction. Okay, that's the atria. It's pretty straightforward and simple. There's not a lot going on there. Now let's talk about the ventricles. This is the guy that's actually pushing the blood out of the heart someplace else. Now, in order for the blood to, let me draw a heart. here. In order for the blood to come from the atria and go straight into the ventricle, the pressure in the ventricle has to be lower, right? Does that make sense to anybody besides me? Right?
Well, I had a question. Can I see if I can find
Okay.
it real quick? That kind of confused me. Sorry, my
Okay.
kids in the background. You can keep going, and then when I find it, I will ask.
Okay, that's fine. So naturally, guys, when we've got this set up so that the blood just goes, it comes into the atria and just falls straight into the ventricle. So the ventricle pressure has to be lower than the atrial pressure. Because if it's higher, it's going to close the door and nothing's going to happen. Now, when that atria contracts after the P wave, he's going to get that little bump because the pressure is going to go up. Well, he's starting to move. He's pushing that blood into the ventricle. So you're going to get a little bump there too. That's not the ventricle contracting. That's just the blood rushing in there. Okay, so that is the ventricle. Now here's our QRS, because there's our delay right there at the AV node. When the QRS starts, then we're going to start squeezing from the apex of the heart, the little pointed side at the bottom, and we're going to squeeze starting from the bottom up. It's kind of like squeezing toothpaste from the bottom of the tube. Everybody doesn't do it, even though it makes more sense, but that's okay. So he's going to start squeezing. He's going to squeeze, and at some point, he is going to go, let me write it down here. So he starts squeezing, and there's the atrial pressure. As soon as he gets higher than the atrial pressure, he's going to close that let's call them the AV valves. And the AV valves are the valves between the atria and the ventricles. So as soon as he's got more pressure, he's going to push those guys and shut. But this green guy up here is the pressure in the aorta. It could be the pressure in the pulmonary trunk too, guys. We just usually do it just with the aorta. Now, even though he's up above this, he's still got a long ways to go to get there. So during that whole time, the AV valves are closed, but say the aortic valve, if he doesn't have more pressure than here, let me do that like that, big P and a little p, he's not going to open that valve. The pressure there is stronger, so that valve is staying closed. So he just keeps squeezing and squeezing, but nothing happens until he comes above the pressure right there. When that happens, then he's going to push open this valve and blood is going to start moving out. That's all that means. Now, this whole time that he's squeezing and he's not got enough to open up that aortic valve, that's the part we call isovolumetric contraction. He's contracting, but he doesn't have enough force to open up the door yet. That's all that means. He simply does not have enough force yet. Now, once he does, then he's going to continue and actually get up to a peak pressure right there. And as he does that, he's also going to cause the aortic pressure to basically be just a very slightly less than what he's got. So he's going to do that. And right here, we've got something else going on. Let's get rid of some of this so I can draw some more stuff. Only have so much room on here. Too bad. Okay, now let's get my pencil back. Well, hello there, little one. Let me guess, you want to sit up here with me? Excuse me. Okay, you get to sit and watch me.
Let's go get you some ice.
You want some ice? Go get some ice, baby. I'll see you in a little bit. So let's finish this up, guys. He goes up, and eventually the ventricle starts to relax. Now that's repolarization, but that's the ventricle is going to start relaxing about about that time. Well, as soon as he drops down below the pressure that's in the aorta, then that aortic valve closes again. Snap. Now he's lower than the aorta, but he's still higher than the atrium. So that means that all the valves are closed. So no blood is coming in or going out. And this guy keeps relaxing until the pressure drops down below the atria again. That is isovolumetric relaxation. That's all that's going on right there, guys. And once he drops below there, then the AV valve opens again and blood starts coming back again to start all over again for the next cycle. Okay. Now we've talked about the pressures, we talked about the valves, let's talk about these sounds. There's the lub and there's the dub. The lub is the sound of the AV valve snapping shut. So that happens right at the beginning of isovolumetric contraction. The dub is going to be once the ventricle relaxes and he drops down right here below the pressure in the aorta, then the aortic pressure is going to snap shut the aortic valve. That's the S2. That's the dub sound. Not a whole lot going on with that. The last thing that we have to deal with is the amount of blood and where it's at. Okay, we start at the P wave. Well, let's start right here. So after this guy falls down below the atrial pressure, then blood just starts to flow in. It's just basically going straight through from the atria to the ventricle. So he's going to go up to about right here. Now, that's the slow ventricular filling. Right there is where the P wave is, and that's going to cause the contraction. And you can see that the pressure goes up a little bit, and it's going to go up yet and more until the ventricles snap shut the AV valve. That's where you see that straight line. That means there's no blood coming in. There's no blood going out. Everything is closed up. Where you see this is where the ventricular pressure goes over the aortic pressure. So that means that the aortic valve is opened. And once it's open, blood starts to leave the ventricle, and that's what you're seeing. That's the rapid ejection, and that's the slower ejection phase down here. That's all that's happening is the blood is leaving. Now, if you look, we're starting with 120 milliliters once the isovolumetric contraction starts. And once the isovolumetric relaxation starts, we're going to have about 50. So not all the blood gets pushed out, but a good chunk of it does. Let's see. Let's go to a different one.
Can I ask my
Oh,
question now?
oh yes, ma'am.
It was about the. Well, I had it pulled up and then I lost it. Okay. Um, it says the question was pressure is low in the left ventricle, 80 Hg. Blood
Thank
passively flows from the atria through open AV valves into ventricles from the atria. SL
Yeah,
valves closed.
yeah. So there's the tricuspid and there's the mitral valve. So when these guys are open, which they open like this, then the blood is just, it's coming in through those blood vessels. It just falls in there all by itself. That's passive. Now, once the atria contract, they actually squeeze about another 20%, maybe 25. That's what that guy said, but the 20 is a good one. And that's where we're getting this right here. See, that's about the time that we get the P wave. So that's going to be the atrial kick right there. It's going to squeeze that extra bit in. Does that make sense, ma'am?
Yes, but it talks about the end diastolic volume at rest is 120 mLs of blood, and then it says choose the answer. And it says the answer is the ventricular filling mid to late.
The answer to what? What question are you looking at?
Well,
Is
it was
this
on
one of the
one.
homework questions?
Yeah, I think it was one of the homework questions. I can show you on Tuesday. That way we can talk about it.
Yeah, end diastolic volume. Systole is when something is contracting, and diastole is when it's resting. The heart as a whole stays in diastole most of the time. But when they're talking about in diastolic volume, they meant this is the total blood in the ventricle before we close it up and we start systole in the ventricle. Okay. Okay, little one. What you want now? So that's all the end diastolic volume is referring to. The end systolic volume is how much blood do you have left after the ventricle contracts and pushes whatever it's going to push out. The passive filling that happens plus the atrial kick is going to equal the end diastolic volume. But that's only going to be the difference. That's only going to be about 70 milliliters because you start at 50 because you don't get that out. Does that make sense?
Yes, sir.
Okay. Any other questions, guys, about anything? It's your time. I want to help.
We haven't gotten to it yet, but the clotting factors, and then like the extrinsic and intrinsic pathway, both of those two things desperately need help
Yep.
with.
Yeah, we will do that. You guys got any more hard questions? Because I'll be glad to go to the blood and talk about the coagulation cascades. Ooh.
Before you move over, before you
Ma'am?
switch, could you give us an example of like a test question about the cardiac cycle?
Oh gosh. Yeah. There's no end of test questions on those. Matter of fact, I gave you some on that quiz that we took the other day, but the end diastolic volume is reached at what point in the cardiac cycle? When do you get to the end diastolic volume? You get there at the beginning of isovolumetric contraction because the final volume is going to be once all the doors are closed and no more comes in and none are going out yet. Does that make sense?
Wait, can you explain the isovolumic?
I'm
What
sorry,
is
explain which one?
the isovolumic? Did you
Oh,
say
I can't hear
contraction?
you. Let's see if I can turn my volume up. Nope, I'm maxed. Let me see.
She said, can you re-explain the isovolumetric contraction?
Sure, there's nothing to that. Let's go to a clean slide. So once the pressure in the ventricle goes up above that in the atria, then that one valve is going to close, right? The other valve going into the aorta is already closed because it's not high enough to be kicked open. At that point in time, this guy is basically totally closed. So you've got two doorways to the ventricle, one from the atria and one going up to the aorta. If both those doors are closed, then there is nothing coming in or out of the ventricle. Does that make sense, guys? Isovolumetric, the only thing that means is iso means the same volume. It just means since all the doors are closed, nothing is coming in or going out. And that is when we get the end diastolic volume. And it's going to start right there. And that's where the ventricular pressure goes above the atria, but it hasn't reached the pressure in the aorta. So that whole period of time right there, which time-wise, they don't have a time cycle on there, a very short period of time because the ventricles start squeezing hard. That's all the isovolumetric contraction is. The isovolumetric relaxation is basically the same thing, only in reverse. The ventricle starts to relax, so the pressure drops. As soon as it goes down below the aorta's pressure, then we're going to close off that valve, but it's still higher than the atria, so that valve is closed too. You got the same thing. You've got the same amount of blood in there because nothing is coming in or going out. And this guy is relaxing instead of contracting. That's the main difference. But once he falls down below the atria, then the AV valve, the mitral valve opens and the blood starts coming back in. How's that, guys?
I'm good.
Any other questions on the heart, guys? I'm not rushing you. We got all kinds of time. Cardiac output, you guys got that down pat? Stroke volume. Y'all have that down pat, guys, or do we need to work on this?
I don't have any of it down pat. It's all confusing to me.
Ooh, that's not good.
I
Okay.
know.
Stroke volume. So the amount of blood you start with in the ventricle, the amount you got left once you're finished contracting. The difference between that is the stroke volume. And that just means that's how much you pushed out. So if we started with 120 and we got 50, then the stroke volume is 70, right? That's the difference. That's all this means right there. The end-systolic volume is just what you got left after the contraction. Heart heart rate, of course, is just how many beats you have per minute. Cardiac output is how much you push out times 60 minutes. Oh, I'm sorry. Times 1 minute. So, and that's going to be times the heart rate. So if I say I've got a heart rate of 60, then that's going to basically go down to 1. So my cardiac output is basic. Well, let's see. Cardiac output 70 times, no, I think it will go that way. Okay. And that's 42. So I pushed out 4,200 milliliters or 4.2 liters of blood. That's all you're doing is taking your heart rate and multiplying it by how much you push out with every beat. That gives you your cardiac output. The ejection fraction. So I said we pushed out 70 out of 120. That's all that is. Let's see. Ejection fraction, I better get this. 70 out of 120. My ejection fractions is 58%, which is good. I mean, that's super simple, guys. Ejection fraction is something that's really important with folks with congestive heart failure. Bradycardia is less than 60 beats per minute. Might not be pathological. It could be, it depends on the person. Tachycardia is more than 100 beats per minute. Tachycardia really depends too, because if we exercise doing aerobics, then we're going to get tachycardia, but that's fine to a certain degree. Anything on this one, guys, that you want to talk about? Otherwise, I'll go to another heart one because I don't want to leave you guys hanging.
You can move on to the next one.
Okay. Okay. Let's see. Yeah, we need to talk about this. Okay, let me get this thing shared. And there we are. Let me go back to black for this one. We talked about that the target heart rate. Cardiac output is going to go up till you get past 120. So if you go from your normal 75 to about 120, you're going to actually get more blood out. But once you go past that 120, you're actually going to start having less blood goes out. And that's simply because when we have our cardiac cycle, we actually have, if we're going to make it, I'm sorry, didn't mean to do that. If we're going to make it go faster, then what we have to do is actually cut off from diastole. And that's the time that we use to fill the heart. So the higher you go past that 120, the less filling time. So even though you're going faster, you're not getting as much blood out as if you were going slower. Autonomic tone of the heart is basically parasympathetic. That's going to be from the vagus nerve. The sympathetic fibers are there. They can increase our heart rate if needed. Let's see. Talked about that. There's the guy that shows us. So there's our normal going. It's going to take a certain amount of time to go from there to there. Now, if I have the sympathetic system, he's going to actually cut that time down simply because he moves the resting voltage from the -60 to like a -50. If I want to slow it down, the parasympathetic is going to stretch it out. All you do is it's going to take the same amount of time for the sodium to get in. And it just depends on how far it's got to go as to how long it takes. That's really all that means. Normally, it takes just a fraction of a time. Let's say that's about 0.2 of a second, maybe. But you can stretch it out 4 times that long, or you can cut it to half that, just depending on how far you move it, either up or down. Does that make sense to you guys? What you think, guys?
How would you word this on the test? I feel like there's so many graphs that's kind of hard to know.
Not really. If I ask you how the parasympathetic system slows down the heart, it's by hypopolarization. In other words, we move the resting potential down. So it was at 60 normally, -60. I moved it to -70 and it stretches it out. It takes them longer to go from -70 to -40 than it does from 60 to 40, right?
Right.
Put it up at -50, it takes a shorter time to get to 40. That's all these graphs are meaning, guys. You just need to know what each system does to make this happen. So I hyperpolarize it for parasympathetic, and then I reduce it. I actually move it up closer to the threshold for the sympathetic system. We talked about the vagus nerve and the sympathetic. We also have input from pressure receptors and chemoreceptors. The baroreceptors are going to measure our heart or our blood pressure. And if the blood pressure is low, it's going to cause a reflex of tachycardia. We're going to make the heart beat faster to try to bring up the blood pressure, because going into shock can be lethal. Chemoreceptors, same thing. If we have too much carbon dioxide building up in our body, then we're going to increase our heart rate to try to get rid of it. The faster the heart rate, the faster the CO2 gets to the lungs, and then the faster we can get rid of it. Proprioceptors, if you're moving your arm a lot like you're in exercise mode, then that can also, it goes along with the chemoreceptors. And then, of course, your emotions can cause your heart rate to go up as well. Let's see. The Bainbridge, if you get increased blood flow back to the atria, it's going to stretch the atrial walls, And when the atrial walls are stretched, just like we said on the skeletal muscle, remember, you got an optimum amount of stretch is going to give you the max contraction. If it's not stretched enough, you're not going to get as much force. And if it's stretched too far, then you're not going to get anything. But you stretch it just the right amount, you're going to get the maximum force. I don't know. You guys might not have had one. When I was little, I had little slingshots, right? Little Y-shaped wood with a little rubber on it. You pulled. The further you pull it back, the faster it's going to go, right? The more stretch you have on it, the faster you're going to get your rock or whatever pebble to go. Does that make sense, guys? Not everybody go out and buy a slingshot and no. That's basically what's going on. And the chemoreceptors, we haven't got there yet, so let's don't go into crazy about it, but carbon dioxide is kind of equal to hydrogen ions. And hydrogen ions are a thing with acidity. Here they're just showing you some things that can increase the heart rate and how hard we contract. Adrenaline, without a doubt. The proprioceptors we talked about. Decreased oxygen, not a whole lot. It's really more CO2. Lactic acid is basically, what you get when you go into glycolysis. The baroreceptors, falling blood pressure. The limbic system, of course, catecholamines are the same thing as norepinephrine. Thyroid hormone, all of this. Nicotine, caffeine, those are stimulants. Okay. Things that decrease it are to be just the opposite, guys. You're not exercising. You get parasympathetic stimulation. You guys remember parasympathetic uses acetylcholine. Lower CO2. Baroreceptors, the pressure is normal or even a little bit more. You're chilled out, no adrenaline. T3, T4 in normal range. So, I mean, it just kind of makes sense. Here's the thing I was telling you guys about the other. There's a slingshot. Kind of a different thing, though. So, Frank Starling mechanism, that's basically what we just got finished talking about. How much you stretch it is going to determine how hard and how much blood goes out of the heart. They call that preload when we're talking about stretch. Preload is the same thing as the EDV, the end diastolic volume. That's how much blood you start with once you've got all the blood in that you're going to get. Now, the Frank Starling thing is just saying the more blood you start with, the more you're going to get out. On a normal heart, you see this is increase in the blood you start with, the end diastolic volume. So the more preload you have, you see the blood volume that you ejected went up. Right there. And that makes sense. Again, the more you stretch it, the more it's going to push out. The harder it's going to contract. Now, somebody who's got heart failure, they are not going to get as much blood out, but they still can get a little bit. So these guys are kind of like they're following kind of sort of in that you don't really get an above average until you get it very stretched. With unmedicated heart failure, you're lucky to get to this, honestly, unless you're giving them some medications. Okay. When we talk about contractility, how hard, we talked about the preload, but there's other things. There's something called contractility, which is kind of abstract. It's contractility. And the other thing is afterload. So if the amount of blood in the ventricle when you start to contract is the preload, the afterload is the pressure in the aorta that you're pushing against. It's a big difference between having a pressure of 80 and a pressure of 100. I mean, if your blood pressure is 130 over 100, the heart is not going to be able to get as much blood out unless it contracts harder. So the things that help our contractility, this kind of vague thing, we're going to call those inotropic. You got positive that helps contractility and negative that decreases it. Congestive heart failure, obviously, you're going to decrease it. We saw that. The afterload, that should be a negative. The afterload is not going to, we'll say we'll give it a positive. It's going to make the heart beat harder because it's got to push against higher pressure. Parasympathetic is going to shut it down. Sympathetic and catecholamines are the same thing. And then the heart rate, the faster the heart's beating, the stronger the contractility is. And one of that reasons is because if it's beating faster, then I'm going to leave more blood in there. And each time this thing fills, I'm going to get more and more. And I'll actually get a higher preload. Dopamine and isoproterenol can actually mimic the adrenaline. Having a lot of calcium, digoxin, is going to lower the heart rate. Thyroid hormone, glucagon, acidosis, beta blockers, all of those are going to shut it down. Okay. Stroke volume, how much blood we push out. Now that's where the afterload is definitely going to be negative. The higher the afterload, the less blood you're going to get out. The blood is going to be, the heart itself is going to beat harder, but you're still going to get less blood out. But if you increase the amount of blood you start with, you're going to get a higher number. Let's just say this. So I've got 120 milliliters of blood. Now, if I get an ejection fraction of 50%, that means I'm going to push out 60 milliliters. But if I take that same, let's put it this way. If I put 140 increased preload and times that same 5, then it's going to be 70. You guys know this. Somebody says, I'll give you 50% of a $10 bill or 50% of a $20 bill. Which one's going to be the biggest? Well, the 20, of course. That just makes sense to me. What about you guys? Is that kind of making sense to you on the preload? Contractility is going to be all of this stuff that we talked about. This is going to increase the amount that we push out. It says decreases the end systolic volume. In other words, we're not going to have as much blood left in the heart after we contract. That's going to increase the diastolic. That's going to increase it because you're not going to move as much. All of this stuff is basically just the opposite. So if I have all of these situations, I'm not going to have as much blood to start with, which means I'm going to have less that pushes out. This one is going to increase the amount of blood I have left after I push out the blood, so I'm going to decrease my stroke volume. This is the one, the lower the blood pressure the heart's pushing against, the more blood it's going to be able to push out. And again, that's a lot of this is just glorified common sense, guys. Does that make sense to any of you guys? Maybe?
Yes, sir.
Okay. I know this stuff's complicated. It is. It really is. These factors, what affects the heart rate and what affects the stroke volume? The heart rate is going to be that atrial, that vein bridge reflex that we talked about. The autonomic nerves going into it, especially sympathetic, the hormones, again, sympathetic, adrenaline, it's going to increase the heart rate. You increase the heart rate, then you're going to increase the cardiac output to a limit. And I would definitely remember that if I was you guys. What determines how much blood gets pushed out? How much you start with, how long you let it fill, and that's all going to affect that preload that we just got talked about. The more preload you have, which just simply means the more blood you start with, the autonomic innervation, whether we're plus or minus, is going to determine how hard it contracts, and that's going to determine how much blood you got left in there. And then the last thing, of course, is just what we said. How much am I pushing against? It's a big difference between 80 and 90 and 100. So that's going to determine the stroke volume. The stroke volume is really going to be more about the cardiac output. How much blood do I push out in a minute? How much blood do you push out with every beat? That's what it's going to come down to. Any hard questions, guys? Anyone?
I don't have any right now.
Okay. Well, let's go to the blood so we can talk about the coagulation cascade. That was one of our questions. I'm trying to remember which PowerPoint that was in. Let's see. Well, it's going to be on the third one. Okay. Oh, let's share that with you guys. And maybe you guys can see it now. Let's see. I don't want to talk about mono. Let's go to a decent looking thing. Okay, guys, there are two things that are going to cause us. That looks a lot better. Okay. Two ways that we're going to coagulate our blood. Now, I don't know what that's for, but that's a good idea. So the damage to the wall of the blood vessel that's going to expose collagen fibers that are part of the connective tissue. Those collagen fibers are going to take factor 12 and turn him on, activate him. 12 is going to turn on 11. 11 is going to turn on 9. 9 is going to turn on 8. And 8 and 9 together will turn on 10. 10 will turn on 5. 5 is going to, we won't use these numbers, we'll just give them their names. It's going to change prothrombin to thrombin. Thrombin is going to take fibrinogen and turn it into fibrin. And then factor 13 is going to help us with fibrin after it's prepared. The extrinsic is, these are going to be damages to cells that are outside the blood vessel. In this case, factor 3 is going to cause 7 to activate. 7 and 3 together is going to turn on 10. 10 and 5 and all the way down is it's all the same all the way down. Now let's go back here. So here's what's going to happen. When you get a cut or damage to a blood vessel, the first thing that's going to happen is you're going to get a reflex on the smooth muscle that's going to try to bring the ends a little closer together, make it easier to plug. That collagen there is also going to cause the platelets. It's going to cause one of them to get sticky, and it's going to stick to the blood vessel. Now, platelets are the only other thing that I know of outside from oxytocin that is positive reinforcement. I mean, this guy, once he's going to cause others to get sticky, and pretty soon you've got a platelet plug. Now, that's not quite enough by itself. So what's going to happen is once that fibrin is there, he's going to go over that platelet plug like this, and that factor 13 is going to cross-link it. And he's going to also cause this guy to shrink and bring the ends closer together. There's a photomicrograph of exactly what's happening. There's going to be some red cells. There's going to be miscellaneous stuff. Plasma is going to be in there. And eventually that liquid is going to turn into a gel, which is exactly what happens when you get a cut. At first it's going to become a gel, and then as it dries out, it's going to become a scab. That's coagulation. Clot retraction, platelet-derived growth factor, the clot retraction. Now, this is how we get rid of the clot once we don't need it any longer. Once the fibroblast and the epithelial cells on that blood vessel have repaired the damage, then we need to get rid of that because it's a liability. So the blood cells or the endothelium is going to release TPA. TPA is going to help with this plasminogen, and it's going to turn it into plasmin. Plasmin is going to dissolve the clot. That's basically it. Now, the reason the clot doesn't run the entire length is we have these plasmin or this PIA inhibition, because we don't want to, take care of clots down there. So we have plasmin inhibitors downstream, but we also have inhibitors against the fibrin so that we don't get it. So here's the thing. Let me see if I can get a long tube. Got this long tube. I need a clot here because it's broken. I don't need any clots anywhere down here. So we actively inhibit clotting down here. And in this area, we're gonna disable the TPA because we don't want that clot to dissolve until it's all completely done. Thrombus and embolism. A thrombus is just another name for a clot. An embolus is a clot that breaks loose and travels. And it usually will go through all these blood vessels until it finds one that's smaller than it is. And then it's going to act like a dam and close it up. Petechia is just, it's really just tiny bleeding because of a lack of platelets, thrombocytopenia, or it could be due to some of these others. Hemophilia, I'm not going to ask you a whole lot about this. Hemophilia is when you lack some factor that's going to cause a problem. This one is factor 8. Factor 9 is B. Factor 11. But some of these, again, there's 2 pathways. So even if one is closed down, you've got another. It's not going to be as good, but still, it's better than nothing. These guys, this is pretty much well controlled. Clotting factors are given to people with hemophilia now. Everybody good with this stuff? Can I put a smiley face here? What you think, guys?
Yeah, I think I have this part mostly down.
Okay. Well, what about the coagulation? You guys, do you get what I was saying, or do I need to do it again?
I mean, I think I kind of understood it a little bit.
This is the one I would look at, guys. This one right here. This is the best one that we've got. Those others are kind of flaky. This one shows everything. And like I was telling you, some of this is pretty easy to remember. If you remember 10 is where everybody's trying to get to, then all you got to do on this guy is 12, 11, 9, 8. I mean, it's in reverse order. And then 10 is where everybody's trying to get. 10 and 5 are going to be the guys that actually cause it. On this guy, it's really just 3 and 7. So it's not too bad. Let's see. Hemostasis, vascular spasm, we talked about. Platelet plug, coagulation, and then that contraction. We talked about this. There's our plot again. Mono, the leukemias. I don't know. Basically, here's the thing. If it starts with an A, it's acute, it's going to grow fast. If it starts with a C, it's going to be chronic, it's going to grow slow. Not going to worry too much about this because we're going to cover that in its own whole chapter. We're going to do that in the lab. Diapedesis, we're going to talk about that in that other chapter. So I'm not really so concerned about doing the immune functions because we've got an entire chapter devoted to that. So we'll catch that after the test. Anything else, guys, on any of these chapters, 17, 18, 19? We've got a pretty good bit of time, and if I was you guys, I would definitely look at some more videos. See there's going to be somebody in those videos. If it's not mine, then find somebody whose video you can connect with. Try the Amoeba Sisters. If they've got one, then that would be the go-to place to start. That is my doodle, and I have no idea what it is. That's okay. What other questions you got, guys?
I don't have any more questions that I can think of right now.
Yeah,
Well,
I'm just
remember, we've
watch
got,
videos.
ma'am,
I said, yeah, I'm just gonna have to continue watching videos.
watch the videos. We've got Monday afternoon and Tuesday afternoon and Wednesday afternoon that if you're having any trouble, you can come on in and we'll go into the lab and we'll go through it. But you got to come with questions, and because it doesn't really do me any good to go through an entire PowerPoint. We've got a whole slew of videos doing that. But I will post this video on the YouTube channel as soon as we're finished.
Okay, thank you. I appreciate your time.
My
Yes, thank
pleasure,
you.
ma'am. I will see you good folks Tuesday.
Okay, see you
Or
Tuesday.
sooner.
Thank you.
Bye.